Rotavirus disease and vaccines. Again, we'll talk quickly about the disease, the vaccine, and I'll give you also some local experience from Jordan. So let's always remember that as we debate the cost effectiveness and cost saving and the money and health economy, remember that we are vaccinating our kids and we are decreasing the mortality and morbidity. If you look at this slide from UNICEF data or WHO data, you will see in 2013 there were 6.3 million deaths of children below the age of 5 years, and many of them occurred secondary to what? To vaccine preventable diseases. This number is now down to 5.9 million. And if you look at the previous old data, it was 9 million deaths. So there are two lessons from here. First lesson, that we are doing good in decreasing the mortality of childhood. But the other more important lesson, we have a lot of things to do also to improve these numbers and get less and less deaths among our kids. So remember that rotavirus disease is almost for each 200 diseases or patients, we end up admitting 40. We end up seeing 40 in the outpatient department, admitting 4, and 1 child might die. And the death is something else. So, and remember also that a child can get more than one disease. All of the kids will acquire rotavirus disease. But some of them will get 2 infections, some of them 3, and some 4. And also in highly crowded area, you might be having 2 viruses in one infection, in one episode. So this will reflect in the vaccine efficacy later on. Rotavirus mortality, if you see, India is number 1. Almost 22% of rotavirus mortality happens in India, Nigeria, and Pakistan. And interestingly enough, these are the countries where poliomyelitis, we still see cases in Nigeria and Pakistan. And usually always we say, whenever you see pneumonia, you see also gastroenteritis and rotavirus infection. So there is considerable mortality. In 2008, it was estimated that we have around 500,000 cases of deaths among children below the age of 5 years, secondary to what? To rotavirus gastroenteritis, that in 2008. However, according to because the situation is improved, vaccination is more used around the world, this number has decreased from around 5 million to almost 215 million. So about 60% change in the mortality secondary to rotavirus, maybe mostly secondary to rotavirus introduction into different communities. Well, we say in the beginning that rotavirus is a democratic virus in infecting all kids, but it is not democratic in killing the kids. So it is estimated that if 55,000 kids in Europe get the disease, only 1 die. However, in low-income countries, 1 in every 500 will die. So yes, all kids get the disease, but not all kids react the same because of the situation they have in their countries. I'm not going to talk much about this, but there are many serotypes, genotypes around us according to the G and B types. So you could have G1B8, which is the most important virus around, that's circulating in the communities of rotavirus disease. But with the combination, most of the common group is infecting a human being is the G, and the most common virus infecting people around the world is G1B8. However, these are the common genotypes that are circulating around. And these are the vaccines that are available. The most important, the most widely used 2 vaccines are Rotarix and Rotatic. Rotarix is a monovalent human G1B8 live vaccine, while Rotatic is a pentavalent or multivalent human bovine reassortment vaccines with 5 viruses inside it and called Rotatic. And there are other vaccines. This is an Indian vaccine, Rotavac, and this is Indonesian vaccines, RV3. And this is a Vietnamese vaccine, which is used actually in vaccine. It was licensed in 2014. And China has the Lanzhou vaccine. I don't know, this is how I pronounce it. I don't know how they do it. Yeah, Lanzhou vaccine. So this is the pentavalent vaccine. The question is, do we need the vaccine? So we have to look at the burden of the disease. This is the very famous publication by Dr. Khouri about the different rotavirus as a cause of severe gastroenteritis in different areas of WHO area. And if you see in Eastern Mediterranean region, rotavirus is responsible for 40% of severe gastroenteritis among kids. And this number is almost less or more, 32 to 47 around the world. Rotavirus is responsible for severe gastroenteritis. The other question, which we will not go into it today, what should we use? Monovalent vaccine or pentavalent vaccine? Some people talk about what we call homotopic protection or heterotopic protection. This is not about, among our objectives for today. However, remember that rotaviruses, genotypes, and groups that infect people or kids in one community, they might be different next season, or they might be different in next location in the country. There are variable genotypes and serotypes that can infect people. So if you look here, this is in 2004, 1993, 2004, G1B8 was the most common. Now G1B8 is being less common than before, and there is more expansion of G2B4 genotype around the world. But you cannot just look at this. You have to look at different areas. If you need to look at the EMRO region, G2B4 is becoming more important, and G1B8 is this. Again, this is variable according to the area, according to the season, and according to the time. So you have to look at your local data. For example, in Jordan, if you can see here, G2B4 is more common than G1B8. That's in Jordan, but in other countries it might be different. And of course, everybody will ask about intussusception, because intussusception was one of the reasons, or the most important reason why RotaShield in 2000 was withdrawn from the market, because it was related to certain cases of intussusception. In big studies, huge studies, the rotavirus 1, which is the Rotarix, the monovalent, is responsible for 0.7, or associated with 0.7 to 7 per 100,000 vaccinees. While Rotatec, the pentavalent vaccine, is associated with 2 to 7.7 per 100,000 vaccinated infants. These benefits are much outweighing the risks of getting rotavirus disease. The genotypes, according to Dr. Dbebo in Lebanon, the genotypes that are running in the area now are G1B8, but more and more now we are seeing G2B4, and G9B8 is also increasing. This is from Jordan, different studies in Jordan in different times, in different locations have shown that rotavirus coverage, monovalent coverage, if you use homotopic protection, will be less than pentavalent vaccine coverage. And this is local data that we have used to decide which vaccine we need to introduce in Jordan. Remember, there is a global emergence of G9B8 and G12B8, and more appearance of G2B4 genotype around the world. So, why is the difference in this genotype? Is it natural or seasonal variation? Is it vaccine induced? Or we don't know yet what is the right answer for that questions. However, we have to remember, very importantly, that the vaccine efficacy is completely different from highly developed countries to low developed countries. The vaccine, whether it is monovalent or pentavalent vaccine, is very efficacious in high-income countries, and the efficacy goes down as you go to low-income countries. It can go up to 990 to almost 40s or 50s in low-income countries, and different reason has been stipulated for that efficacy. One of them is they are talking now about something called environmental enteropathy in those kids who are living in low-income countries. And some people also are showing some evidence that co-administration of oral polio virus vaccine at the same time concurrently might decrease the immune response to the rotavirus vaccine, or a presence of maternal antibodies that might be much more prevalent in low-income countries, population density, or coexisting rotavirus disease. You having more than one rotavirus causing a disease, and now there is a hot subject called different affinity to histoblood group antigens, and don't ask me about it, I don't know exactly what it is, we have to read about it more. However, what are things that we could use to increase efficacy? Some companies using adjuvants to increase the efficacy of these vaccines, developing new novel vaccines. I have shown you some new vaccines that have been developed, changing schedule, maybe separating oral polio vaccine from the rotavirus, or increasing the number of doses. These are some schedules that we could look at. WHO says that rotavirus vaccine is very efficacious and should be used among other healthcare preventive methods like safe water in countries where mortality seems to be high secondary to rotavirus disease. Okay, in Jordan, in 1 minute, I will show you what we did when we introduced our vaccine. We looked at our local data and we found Dr. Nafi was a leading author in one of the articles that showed that rotavirus in Jordan is responsible for around 40% of our severe gastroenteritis patients admitted to the hospital, 40%. There are different other studies. Then we used our mortality data and we did a dynamic modeling what we're going to be gaining if we introduce the vaccine into our children, and these are some data. We end up calculating that per each Cali, for each quality adjusted life year in Jordan, we're going to pay almost $8,000. In health economics, if you pay less than 3 times your gross domestic product, and the gross domestic product in Jordan is about 6,000 per capita, which is 18,000, the 3 times, it's going to be cost effective. So the vaccine was introduced, and we chose to use the RV5, the pentavalent vaccine, and this was done in March 2015, and this year it is the 3rd year after introduction of rotavirus vaccine to our Jordan. One very important issue, we coupled the vaccines to already existing schedule, so the coverage was more than 95% from the beginning for our vaccine, and I can show you these data. These are the cases of severe gastroenteritis admitted to our hospital after introduction to the vaccine. And I can tell you, our rotavirus, we still have to analyze our data, that this vaccine has been very efficacious, actually more than we expected. We expected a 60 to 70%, but it seems to be more efficacious in our community. This is an example of how can you use your local data in introducing a new vaccine, then you couple it with surveillance after that to see how is it doing. So thank you very much. And this is again a second picture of my university, and that's our hospital that we work in, King Abdullah University Hospital. And thank you very much.